Hello, today we will look at heart failure and we will see what we need for diagnosis of heart failure. Usually we need symptoms, signs, we need some lab tests, we need an ECG, an echocardiograph, and so on. And first of all, we will deal with the symptoms. So the patient comes in and he complains about dyspnea, so meaning difficulty breathing, especially on exertion. So difficulty breathing on exertion, fatigue, swelling of the legs, for example, swelling of the legs, orthopnea, meaning he's having difficulty breathing when he is lying down, and also paroxysmal nocturnal dyspnea, meaning he has severe difficulty breathing during the night, and it is paroxysmal, meaning it comes and goes, and dyspnea at rest also, so the patient is sitting down and he's still having difficulty breathing regardless of exertion. This is a more severe form of heart failure. Then we can also see diaphoresis. This means that the patient is sweating a lot, but there's obvious no sign of high temperatures in the room and so on, but the patient is still sweating a lot. We call this diaphoresis. So in conclusion, we can say the patient comes with the symptoms of difficulty breathing on exertion or at rest or laying down or in the night. And then we can see swelling of the legs, fatigue, and a lot of swelling and sweating. Yeah? So sweating, diaphoresis. The signs, as we said, are edema, so lower leg edema, for example, elevated jugular venous pressure, meaning that the veins in the neck region are distended. So due to the pressure, it's distended, and therefore we call it elevated jugular venous pressure. We can see pulmonary raise, and that is when we auscultate the lung with the stethoscope. Pulmonary raise. We can also hear extra heart sounds like S3 or S4 sounds. We call them extra heart sounds. There can be a displaced cardiac apical pulse, meaning, for example, that the apex, the tip of the heart, is displaced, for example, to the left. So we have an hypertrophy, so an enlargement of the heart, and it is displaced to the left, for example. The extremities can be cool and very pale. So cool extremities, pale extremities. What we also can see when we palpate the abdominal region of the patient is that we have hepatomegaly, that meaning liver enlargement. Megaly is enlargement. So hepato is liver, megaly is enlargement. So hepatomegaly, and also splenomegaly. This means that the spleen is enlarged. Splenomegaly, so enlargement of the spleen. And also ascites, meaning we have a lot of water in the abdominal region. So ascites. Okay. Just by looking at the patient, we can say that, yeah, this patient has heart failure. And the common thing to do now is to make some other tests, and this would be a chest X-ray, for example, chest X-ray, and we can do an echocardiogram, and we can do an electrocardiogram, so ECG, we have an echo, and we have also a lab test where we check the brain natriuretic peptide. So natriuretic peptide, BNP, it's abbreviated as BNP, brain natriuretic peptide. And also the standardized version of this BNP is the NT-proBNP, so N-terminal proBNP. And usually we use this NT-proBNP. But when doctors talk about lab values, we usually just refer to BNP. It's the same thing. This is a peptide now that will be released into the bloodstream when, for example, the atrium of the heart gets enlarged, the pressure is increased, and therefore this increase in pressure will release this peptide into the bloodstream, and that is what we can see in heart failure. Whenever we try to diagnose now patients, we need to, of course, rule out that, for example, COPD, so chronic obstructive pulmonary disease. So if a patient is smoking a lot, we need to rule out chronic obstructive pulmonary disease because these diseases can, of course, have very overlapping symptoms. So the symptoms can appear completely the same for both of these diseases. Therefore, what I said, BNP is good. Then we have an ECG, then we have an echo, then we have a chest X-ray together with all these symptoms. What we will do now when we do an echo is that's an ultrasound test, and we will check for if the ventricular function now is reduced or not. And then we can divide the patient into reduced ejection fraction heart failure or with preserved ejection fraction. We usually abbreviate it as HFR, EF, that is standing for heart failure reduced ejection fraction. And then we have the preserved one, what we abbreviate as HFP, EF, that is heart failure preserved ejection fraction. The most common cause of this reduced ejection fraction is in the left side of the heart, so it's a left ventricular dysfunction. But in echo, we can also see many other causes also. For example, maybe it's a valvular disease. So the mitral valve can be regurgitating, or it can be stenosed. So it meaning that the flow is either going in opposite direction, in mitral regurgitation, so it regurgitates. As we know, the blood flow usually flows from the atrium to the ventricle. But if we have a severe mitral regurgitation, the flow is actually flowing a little bit backwards. So it flows from the atrium to ventricle, but then it goes back and regurgitates and goes from the ventricle into the atrium again. That can be a cause for heart failure. And also a stenosis. Mitral stenosis just means that the mitral valve is having a less diameter than it should be. And therefore, the pressure will be higher than in the atrium because it have to really struggle to make the blood flow from the atrium to the ventricle because it's a stenosis. But there exists also stenosis problems, for example, in the aortic valve. And we can also see there aortic regurgitation or aortic stenosis. So as we see, when we're talking about valves, we can either have a regurgitation or a stenosis. And we can have that in the mitral valve or we can have that in the aortic valve. And this is usually what we see in the left heart. We have a problem in the left part of the heart. Mitral valve in the left part. But there are also problems sometimes in the right side of the heart. For example, when we have a very high pressure in the lungs due to, for example, COPD, so chronic obstructive pulmonary disease, then the COPD is making that the lung is having high pressure and therefore the blood flow from the right part of the heart, so the right ventricle, can very, very hardly make the flow from the right ventricle into the pulmonary system. And then we call it that we have a cor pulmonale, meaning we have a heart problem due to a lung problem, pulmonale. Pulmonale is a lung problem. So therefore, we have a high pulmonary hypertension. So blood pressure is high in the lung, causing then that we get a cor pulmonale, meaning a right ventricular failure due to the high pressure. The most common cause of this whole thing is COPD. And the most common cause of COPD is smoking. So smoking can cause a right ventricular heart failure by increasing the pressure due to COPD, and therefore the right ventricle will struggle to pump the blood into the lungs. Another very common cause of a heart failure problem can be increased blood pressure. And that's a very, very common thing. So one can say people above 40 years of age, I would say almost half of all people above 40, 50 years of age have blood pressure. Regardless if they know it or not, usually they have high blood pressure, and that can cause an increased thickness of the heart. And then we call it hypertrophic cardiomyopathy. Hypertrophic means it's an increased, trophic means the increased not swelling, but increased size of the heart muscle. And that is a very, very common cause of heart failure. So it's important that you treat blood pressure in people. It's important that you don't smoke, because that can cause COPD, as we said. It's important that, of course, your mitral valves are functioning good. But the things that you can do to prevent heart failure is, of course, not to prevent mitral and aortic regurgitation stenosis, because that's something that you are usually born with, and you usually get this disease during your lifetime. But the thing that you can stop is smoking, and the thing that you can stop is to have a high blood pressure, either by reducing your weight or by taking medications. So now let's look at a case where we have an echocardiograph. So an ultrasound now, and we're dealing with a ventricular ejection fraction that is less than 40%. We call this then reduced. This is the reduced heart failure type. And then we have the symptoms that we mentioned previously, and we see the patient have this elevated jugular venous pressure, so the distended veins. We can hear maybe an S3 sound, because usually there exists an S1 and S2 sound in auscultation of the heart. And then we can see an S3 sound also here. In chest x-ray, let's say we see curly B lines, and this is something that we can see when we have, for example, pulmonary edema, so a little bit more water in the lungs than it should be. Then what we see also is that the ejection fraction, as we said, is less than 40%, but we also see that the diameter of the left ventricle in the end diastolic part, and the diastolic phase, meaning we have a systole and a diastole. Systole is when the ventricle is contracting, diastole is when the ventricle is relaxing. And when we see that the ventricle is relaxing and the diameter of this left ventricle is brighter than 5.8 centimeter in, for example, men, and 5.2 centimeter in women, then this is also a sign of heart failure. So the diameter is enlarged. Then we also can see in the echocardiograph that the inferior vena cava that comes from below, from the abdominal region into the heart, this is more than 2.1 centimeters, so it's distended. And this distension, this more than 2.1 centimeter, will collapse when the patient is taking a sniff. So the patient is taking a sniff and he's contracting his muscles in abdominal region, and then this contraction will cause a 50%, so more than half of this inferior vena cava diameter of more than 2.1 centimeters will collapse. And that's also a sign. And then we also see some NT-proBNP levels in the lab, as we said. We can see that, for example, the level is more than 450 picogram per milliliter, so more than 450 picogram per milliliter in patients that are less than 50 years of age. If it's more, then this is also a sign of heart failure. If it's more than 900 in patients who are 50 to 75 years of age, then this is also a sign. And if it's more than 1,800 in patients that are more than 75 years of age, then that's also a sign. So we see that with age, this NT-proBNP level will increase normally, so naturally. That meaning below 50 years of age, we have a level that is more than 450. 50 to 75 years, we have more than 900. And more than 75 years of age, we have more than 1,800. Now, what will we do now? We have a patient who is having a reduced ejection fraction. We know that he has heart failure with all these symptoms, all these lab tests, everything. Then we have to start a medication. And the question is, which ones? We have a compensated patient, we call it. That meaning he's not decompensated, so he's not struggling for his life due to difficulty of breathing. He's more a compensated, stable patient with light forms of symptoms, then we will start a medication with sacubitril valsartan. Sacubitril valsartan. And we will have a starting dose of, let's say, 24 milligram / 26 milligram. Or if the patient is having high blood pressure also, then we can start with the 49 milligram / 51 milligram. And we will give that orally twice daily. And it's very important to, of course, check if the patient is already taking some medications for hypertension. Because if he's taking already an ACE inhibitor, then we need to remove that. Because the valsartan part, sartan, that is an angiotensin receptor blocker, and we're not allowed to give an angiotensin receptor blocker together with an ACE inhibitor. So we have to choose one of these. And therefore, I'm as a doctor, usually I prescribe angiotensin receptor blockers because I have the advantage of not having, for example, cough, because ACE inhibitors can cause cough. I have the advantage also with valsartan that it is not causing any angioedema, which can be caused by ACE inhibitors. And then, of course, I have this third advantage that I can give it with this sacubitril, and then it's a very good treatment for heart failure patients. And if I start a medication for hypertension and I see that valsartan is working very good, then I just continue with sacubitril valsartan. Of course, then I need to remove the valsartan already what I gave, because I cannot give it double dose. So if you already are taking valsartan, then please, now you will switch to this sacubitril valsartan. We said we will give now the doses of 49 milligram / 51 milligram twice daily. And we always have to check liver function. It has to be normal or only very mildly impaired. And we can classify the impairment of our liver with a classification system called Child-Pugh class A, for example, in this case, when we're talking about mild. So we have A, B, C, D, and here we have Child-Pugh class A, and in that patient, we can start with this sacubitril valsartan with no problem. What we have to check then around 1 week later is to check the electrolytes, especially potassium level, and we also have to check the kidney function. So these two parameters has to be checked when you start the medication with valsartan and sacubitril. The question arises when, for example, the patient cannot take any valsartan, so he cannot take any angiotensin receptor blockers. In this case, we need to give beta blockers, and we will, for example, give bisoprolol 1.25 milligram once daily. So we will start with this dose. And of course, in these cases, we have to check before we start any contraindications, for example, asthma and so on. Or if the pulse is too low, let's say it's lower than 60 beats per minute. So there are some contraindications to beta blockers, and please check them out first, and then you can start with bisoprolol 1.25 milligram once daily if the patient is not able to get these angiotensin receptor blockers, for example, valsartan and sacubitril, which is very, very good. It has been proven to reduce all mortality rates in patients with heart failure. The question arises, let's say the patient cannot take angiotensin receptor blocker, so he cannot take valsartan. He cannot take bisoprolol, so this is a beta blocker. What do we do then? Yeah, then we need to go for another type of medication called hydralazine plus isosorbide dinitrate. And we have to also ask our question here, do we have any contraindications for that? Then you check the table for what are the contraindications. For example, we try that already sometimes in the patient's life, and he got a severe hypotension, so meaning blood pressure dropped very drastically, lower than 90 millimeter mercury, and so on. And if that is the case, he cannot take this hydralazine. Yeah, then the last option here, we have mineralocorticoids, receptor antagonists. Mineralocorticoid receptor antagonists. I will not deal with all these specific groups of medications. I just want to highlight which ones to choose. So we had, first of all, angiotensin receptor blockers, then we had the beta blockers, then we had hydralazine, and then we had mineralocorticoid receptor antagonists. And for example, when I said hydralazine, I mean hydralazine together with nitrate. So this is a combination, and usually there exists combination pill, so a combination tablet of both of these. And we start the dose of hydralazine, for example, 25 to 50 milligram 3 times daily. And the dose of the isosorbide dinitrate is 20 milligram 3 times daily. But let's not go so far here. As we said, most of the patients, I mean more than 90% of patients, will benefit from valsartan and sacubitril. And most of them will have no problems with it, no side effects, and therefore that's the golden rule to start with valsartan, sacubitril in patients who have a compensated heart, meaning they are not critically ill. Because if they're decompensated, then we have another treatment option here. This decompensated word is a very broad term, as it's very hard to say what do we mean now with decompensated. We usually clinically refer to severe dyspnea, so difficult breathing even by sitting down and doing nothing. We have a lot of hypervolemia, meaning a lot of fluid here in, for example, the veins, and then we have this elevated jugular venous pressure. Also a lot of fluid in the legs, then we call it peripheral edema. We see a lot of pulmonary edema, so lung fluid in the X-ray, and so on. So this is the whole picture, and then we say this patient is decompensated, and this patient is now in the hospital, because usually this patient comes to the hospital, and there they will be treated in the hospital. So it's completely other treatment than we're dealing with a compensated patient that is treated at home by the family doctor. And also we can divide this decompensated patient now in the hospital into somebody who is unstable. When we deal with somebody who have decompensated acute heart failure and is also at the same time very unstable, then we are dealing with somebody who has a ventricular tachycardia. So the ventricle pump function is pumping more than 100 beats per minute. He gets almost no oxygen into his body. He has very difficulty breathing, and as we said, a lot of fluid everywhere. In this way, we call it a life-threatening patient. And here usually we have to have a very highly advanced team that can manage this in a heart ICU unit. So a heart unit in the hospital where sometimes the patient needs a cardioversion. So an electric shock to stabilize the patient, to stabilize the rhythm. So that is one thing that you need to assess. What is the pulse of the patient? How does the ECG look like? You also have to assess how is the oxygen in the blood. So the oxygen saturation. If you see that it's less than 90%, then you need to give oxygen. Otherwise, please don't give oxygen. I know that the patient is having difficulty breathing, but if the oxygen saturation in the blood is more than 90%, you don't have to give oxygen, because if you do, then you can cause a little bit of vasoconstriction, meaning that the arteries will be constricted in the heart, so the heart arteries, and therefore you can decrease actually the cardiac output. So the cardiac function can decrease because it doesn't get so much oxygen due to the vasoconstriction. So it's very, very paradoxical. You try to give oxygen through the nose of the patient. Yes, it's true that you give oxygen to the nose of the patient, but this will cause a vasoconstriction, meaning the arteries to the heart will be constricted, and therefore the blood supply to the heart gets lower. So if the patient is having a good saturation, meaning the percentage of the oxygen in the blood is more than 90%, then you don't need to give any oxygen. So to recap, we can say that the patient comes with difficulty breathing, we see that the oxygen level is more than 90%, then we have to think of other causes. For example, the patient got an acute myocardial infarction. That is a very common cause of acute exacerbation, meaning a decompensated heart failure. So he had the heart failure and he got a myocardial infarction. And then we need to check this by checking the lab values if the heart enzyme have increased. For example, troponin T or CK values, or the creatine kinase values. And in this way, we need to treat acutely myocardial infarction with cardiac catheterization. So revascularization of the vessels, or the arteries of the heart muscle. And this decision have to be made very, very quickly, because myocardial infarction will kill a part of the heart muscle which will not be able to regenerate if it doesn't get the revascularization procedure in a timely manner. We're actually talking about within 1 hour. So therefore, the decision in the hospital has to be very quick. Let's say that the patient does not have acute coronary syndrome, so no myocardial infarction. Then another very common cause of this difficulty breathing can be atrial fibrillation. And atrial fibrillation, as we know, have sometimes very fast beats. So we're dealing with a atrial fibrillation that is in a tachycardia region more than 100 beats per minute, and usually more than 120 beats per minute. And therefore we need to control the rate. So we need to reduce the rate with medications first. And if this does not help, then we actually need to consider cardioversion. And the cardioversion is actually an electric shock. And you will give this electric shock, and then the patient will get into sinus rhythm again. Sinus rhythm just means that we have an ECG that we take from your heart, and there we can see some waves. And the sinus rhythm is when we have a P wave in the ECG. And in atrial fibrillation, there is no P wave. So the beat is more than 120 beats per minute, for example. He's having no P waves. And then you get an electric cardioversion shock, and then you will have a sinus rhythm again, and the patient's pulse will go below 100, and the difficulty breathing disappears. So that's a very common cause of acute decompensated heart failure. What about cardioversion now? Can we do it in all type of patients? Actually, if you see in the chart that the patient did not take any oral anticoagulation, so he's not getting it chronically, then it can be dangerous if you have a thrombus in your heart. So if you have a thrombus in your heart ventricle or atrium, and you give a shock, so electrocardioversion, then this thrombus can then travel into your brain and you can get a stroke. Therefore, it's very important to actually take and check an echocardiograph. You will check an echocardiograph, and especially the transesophageal echocardiograph. And that echocardiogram will now be able to more clearly see the atrium and ventricles. A normal echocardiogram is also good, what you make through your chest region, but a transesophageal one is the most precise method to rule out any thrombus, and then you can do the cardioversion. Now let's turn back to the topic that we dealt before cardioversion, that we said that we need to reduce the rate with medications. We always try to do that before considering cardioversion with electric shock. The important thing here is before we start any type of medication that lowers the pulse, we need to check the ECG for any Wolff-Parkinson-White syndrome. That is when we have the PR interval, so the P wave and the R wave in the ECG is very shortened, and also we see a delta wave. Delta wave means that this QRS complex is brighter, is more than 0.12 seconds, and it's forming a delta shape wave. When we see that type of wave, then we need to watch out, because we cannot give the regular medications that we usually give, for example, beta blockers, amiodarone, digoxin, or calcium channel blockers. These are then contraindicated when we see Wolff-Parkinson-White syndrome. In these cases, we should rather choose a medication that is called ibutilide. Ibutilide. And it's a very simple dose that we can remember here. We will give 1 milligram of this medication over a 10-minute period. So this will be an infusion that we give. If we see that this arrhythmia, so this heartbeat is not normalized within this 10 minutes of infusion, then we start another dose of 10-minute infusion with another 1 milligram. And that's it. So we'll do it 2 times. And that is the medical trial of getting the rate controlled. And then I talked about if we don't succeed, then we need to consider electric cardioversion with shock. The other medications that I mentioned, namely calcium channel blockers, beta blockers, and amiodarone or digoxin, these 4 types can be given in patients who don't have this Wolff-Parkinson-White syndrome. So in those patients, the regular ones will get calcium channel blocker or beta blocker or amiodarone or digoxin. And we have seen usually that those who have preserved the ejection fraction, meaning those who are 50% above, those will get rather beta blockers and calcium channel blockers. And those who have reduced ejection fraction, meaning less than 40%, those will usually get amiodarone or digoxin. Whenever we are not sure about how the ejection fraction is, then we should always treat it as if it was a reduced one. But in my opinion, an echocardiogram should always be done, and we should always categorize patients with reduced ejection fraction, preserved ejection fraction. And when choosing amiodarone or digoxin in patients with reduced ejection fraction, we have seen that amiodarone is the leader. It seems that it's more effective than digoxin. And we will give a dose of 300 milligram intravenously over a period of 1 hour. And we can follow this up with an infusion of around 10 milligram per hour for 24 hours. Sometimes even more. And in patients who have preserved ejection fraction, we usually give calcium channel blockers, and we're dealing with non-dihydropyridine calcium channel blocker. This is called diltiazem, and we will give it intravenously, so in the vein. If we use a beta blocker, it's called esmolol, for example, and also intravenously. And we have seen that this calcium channel blocker, this diltiazem, is very, very good. And this is, as we said, in preserved ejection fraction. And we will give a dose of around 0.25 milligram per kilogram of weight of the patient. And we'll give that in rather short time, so within 2 minutes. And usually around 20 milligram is given. But if you calculate 0.25 milligram per kilogram, we would see that we are dealing with a patient with 80 kilograms. That would be around 20 milligram. So one can remember around 20 milligram here. And we will follow that up with a continuous infusion of around 5 milligram per hour. If necessary, we can titrate it up to 10 milligram, and if really necessary, then up to 15 milligram per hour. But we can start with 5 milligram per hour. And if this initial bolus, we say, the initial 2 minutes of diltiazem of 20 milligram is not sufficient to slow this heart rate, then it's possible to give a second bolus before starting a continuous infusion. So let's say we gave 20 milligram and we saw that nothing really happened, then it's possible to give another bolus of this 20 milligram. Another important thing to consider when we're dealing with oxygen, we said that we have a patient, for example, and he's having an oxygen of let's say 90%, less than 90%. We need to check the chart if the patient is having a COPD, because this is a chronic obstructive pulmonary disease due to smoking. And the target level of COPD patients is not so high as in normal people. So we are dealing with around 88 to 92% of oxygen saturation in the blood in normal conditions. So if this patient have COPD in their chart and you know that he has COPD and you see that the oxygen level is around 90, let's say 88, then you should not panic and you should actually not consider in aggressively giving him oxygen once again, because this is his normal state. And of course, if he's having very difficulty breathing, then you can give oxygen, but try to aim for a target around 92%. So I think we will stop here, and please watch this video many times because it has a lot of information. I wish I could highlight the most important aspects of heart failure treatment. Have a nice day. Take care. Bye-bye.